So hi everyone, and thanks for the opportunity to present again today. I wanted to present a bit on the management of male incontinence because certainly in Ireland at least I think it's an area of urology that's often underdiagnosed and perhaps undertreated. Um, I'm going to review the anatomy of the male sphincter complex, outline current surgical options to treat male incontinence, and highlight some of the innovative ideas and future developments in this field. We're very familiar with the concept of female stress incontinence following childbirth, but males, of course, can also develop stress incontinence, and this occurs primarily post-prostatectomy, and which represents 95% of patients with stress incontinence. Patients might also develop stress incontinence following an overzealous TERP resection or following certain types of posterior urethroplasty. At the Virtual Bout conference this year, there was a talk on prostate cancer survivorship care, and the speaker presented the following data from NHS England. And so in 2019, there was 8,678 prostatectomies in the NHS in England, and the speaker estimated that 1,128 of those would develop moderate to severe post-prostatectomy incontinence, and he estimated this figure based on PROMS data from the PROTECT trial, which showed a 13% moderate to severe post-prostatectomy incontinence. For those who don't know, the PROTECT trial was a randomized control trial comparing active surveillance, prostatectomy and radiotherapy in patients with clinically localized prostate cancer. In 2019, there was also 370 anti-incontinence procedures performed, and assuming a stable incidence of prostatectomies and anti-incontinence surgery, this would represent 4% of radical prostatectomies, but only 1/3 of those with post-prostatectomy incontinence. So what's the local data like here in BC? Well, this graph shows the annual rate of anti-incontinence procedures performed in patients with prostate cancer in BC, and also the annual rate of radical prostatectomies performed. I generated this data from BC Data Scout, which is based on MSP billing codes. The data needs to be interpreted with caution because Data Scout is a tool designed to be used as a feasibility tool, and the data or the patients aren't cross-linked between the two cohorts. However, it appears at least that the number of patients undergoing anti-incontinence procedures in the province is about 10% of the number of patients undergoing radical prostatectomy. Initially, I thought this figure was rather high, and I certainly think it will be interesting to look into the data a bit further. I don't think it means that the outcomes here in BC are any worse than elsewhere, but I think perhaps we're a bit better at addressing post-prostatectomy incontinence when it does occur, particularly because 2/3 of the anti-incontinence procedures performed were slings, suggesting a more mild to moderate level of incontinence. And before I delve into the treatment for post-prostatectomy incontinence, I'm going to talk a little bit about the sphincter complex. So functionally and anatomically, it's composed of two components. The lithosphincter, which is the internal urethral sphincter, that's composed of smooth muscle and it's under involuntary control. And then the rhabdosphincter is composed of skeletal muscle and it's under voluntary control. It's horseshoe shaped and deficient posteriorly where it attaches to the median raphe. During prostatectomy, the majority of the internal sphincter is excised, and post-prostatectomy continence relies heavily on the remaining rhabdosphincter function. In addition to the sphincter complex itself, there's also disruption to a number of structural components, which provide perhaps a passive element to the continence, and the main ones would be the puboprostatic ligaments, the endopelvic fascia, and then umbiliary fascia. There are a number of methods that we've employed to try and reduce the level of post-prostatectomy incontinence, intraoperatively maximising the urethral sphincter length, nerve sparing where oncologically safe. Some surgeons would advocate for limiting the damage to passive support by approaching a rectus sparing approach or posterior dissection, or trying to reconstruct the posterior support using a Rocco stick. I think everyone would agree that pelvic floor exercises are useful in rehabilitating the remaining sphincter, at the very least, providing an earlier return to continence. People have also looked at pharmacotherapy in terms of augmenting the residual sphincter function. Duloxetine has been trialled to augment the rhabdosphincter function, and alpha agonists have been suggested to improve the tone of the internal sphincter. Neither of these have had particularly impressive results. They're not FDA approved for this use, and they're not recommended in the AUA guidelines. Then in patients who do not wish to pursue any intervention, methods employed to contain leakage, like using a penile clamp or a catheter condom or pads. Bulking agents can be useful in patients who want to have an intervention but don't want to have a sling or a sphincter. Again, these aren't actually FDA approved for the treatment of male stress incontinence, and they're not recommended in the AUA guidelines due to the fact that the procedure needs to be repeated and it doesn't have a very high efficacy rate. This was a nice paper published in the Journal of Clinical Urology last year showing 5-year data by Yang and colleagues. This looked at 34 patients with a follow-up of 12 months. 75% of patients who used one pad preoperatively achieved continence, and 36% of those who used two pads preoperatively achieved continence, but no patients who had more than 2 pads per day or had a history of previous radiotherapy achieved continence following the procedure. So where are we at the moment? At the moment, we have the option of an artificial sphincter, a non-adjustable sling, or an adjustable sling. The AUA and CIFU guidelines recommend a stratification according to incontinence, where patients with mild and moderate incontinence are offered a sling, and patients with severe incontinence are offered an artificial sphincter, which provides greater efficacy, but also has a higher rate of complication and malfunction. The first AUS was brought to market in 1973, and it was developed by Bradley, Scott, and Tim, who were a neurologist, a urologist, and an engineer. I had the privilege of hearing Gerald Tim speak at the AUA a number of years ago, and it was really illuminating to hear how the development of the AUS came about. The AS721 was composed of a two-piece pressure regulating balloon. They had 2 pumps, one for inflation and one for deflation, and the device was used for a period of 3 years before it was modified. The device we're more used to seeing today is the AMS 800, which has a single pump and a single pressure regulating balloon, and usually a single cuff, although a tandem cuff is also available. There were 2 device modifications that were made in an effort to reduce the rate of erosion. The first was a deactivation button, which now allows us to implant the device with the cuff empty, not applying pressure to the urethra, to allow it to heal and revascularize before the device is activated. The second modification was a modification to the cuff itself. The cuff has a narrow back with a cushion on it, which allows a more even distribution of pressure across the urethra. There are a number of challenges with the artificial sphincter. Infection and erosion can be particularly problematic because it usually leads to device explantation. these devices are also prone to mechanical malfunction in up to 30%. And with long-term use, subcuff atrophy of the urethra can occur, and this can also result in the device needing to be explanted. There are a number of steps that we take to try and limit the risk of infection with implantation of these devices. The sphincter is impregnated with inhibisome, which is a combination of rifampicin and minocycline. This transition was made based on impressive data of the use of inhibisome in penile prosthesis, but unfortunately the data with the sphincter is less impressive, and some critics would suggest that it's because the pressure regulating balloons cannot be treated with inhibisomes. We obviously give perioperative antibiotics as with the implantation of any prosthesis. We perform a 10-minute scrub prior to pressing and draping, and we irrigate the field copiously with broad-spectrum antibiotic solution like bacitracin. In terms of preventing erosion, careful attention to the cuff sizing at the time of initial AUS placement is of vital importance. There are also patients which are known to be at risk of erosion and have a so-called fragile urethra, and these will be patients with a previous history of radiotherapy, urethroplasty, or previous AUS insertion. And these particular group of patients may benefit from a tandem cuff insertion or a transcorporeal cuff insertion. The AMS 800 also exists as a tandem cuff, which consists of two cuffs that can be placed on separate areas of the urethra, thus distributing the compression across a greater area and hopefully reducing the risk of erosion while increasing the efficacy of the device. There are no trials directly comparing the tandem cuff with a standard cuff insertion. However, Moore and colleagues published a study in 2019 in the DJU where they looked at a series of 150 men with a fragile urethra who had insertion of a tandem cuff with a follow-up of 24 months. 77% achieved continence with a 15% erosion rate. Comparing this to single studies looking at the standard cuff insertion in this high-risk group, they achieved 56% continence with a similar erosion rate. So it appears that the tandem cuff at least does provide an increased efficacy, if not an increased erosion rate. And for transcorporeal cuff placements, corporotomies are made either side of the urethra, and a sale of tunica albuginea is raised and incorporated into the cuff. This avoids the need for excessive dorsal dissection of the urethra, and hopefully in doing so reduces the risk of dissection injury. By including a sale, it adds an additional layer of protection against erosion. It increases the girth of the urethra, hopefully providing a better fit for the cuff. While I was in Edmonton, I looked at a series of patients with fragile urethra who had a transcorporeal cuff or a standard cuff inserted. This was a retrospective study, and you can see from this table our inherent bias towards placing a transcorporeal cuff in these high-risk patients with severe incontinence, because the transcorporeal cuff group did have a higher rate of preoperative pad use. However, in spite of this bias, they had a greater improvement in mean change in pad usage post-operatively. They had a lower revision rate of 20% versus 36% in the standard cuff group, and they had a lower erosion rate of 8% versus 17% in the standard cuff group. So this suggests that transcorporeal cuff placement might provide better efficacy and a reduced revision and erosion rate in this high-risk group. So as I discussed earlier, the artificial sphincter is challenged by a high mechanical failure rate, but also in addition to that, the patient has to manually operate the pump every time they want to empty their bladder. So they're constantly aware of the fact that they can no longer void in a physiological manner. This patient-driven desire towards normal voiding, in addition to a search for a more durable treatment option, led to the introduction of the male sling in 2002. The initial slings introduced were fixed. The first sling was the Invant sling, which was a bone-anchored sling, and this is no longer available due to high rates of perineal pain post-operatively, affecting about 3/4 of patients. The bone anchors had a tendency towards migration, and there was a 15% explantation rate due to infection. And the Advanced thing was introduced in 2006, and I think it's a thing that most people are probably familiar with. And then the other fixed thing on the market is the Virtue thing, which is a quadratic thing with 4 arms. The pros of fixed thing is that it allows passive voiding, and the patient doesn't need to manually operate any device in order to void. It has a low complication and explantation rate, at least in the case of the Advanced sling. But the cons are that it has a lower efficacy than the AUS, and most of the papers reporting on things will report on pain complications of 10 to 15%. Although it must be said that the AUS papers generally don't comment on pain complications, so it's not really clear whether they occur or not in these patients. Adjustable slings were developed as a compromise between the fixed sling and the AUS. They can be adjusted post-operatively, and they can be useful due to the very narrow error margin between excessive urethral compression causing retention and device erosion, and insufficient compression causing persistent leakage and failure to achieve continence. The Argus T and the Remix slings can both be adjusted suprapudically. The ProAct isn't a sling as such. It consists of 2 inflatable balloons which are used to externally compress the sphincter. This device has been around for about 10 years, but it has a high failure and explantation rate, and I think it's probably why it hasn't been more widely adopted. The Atom sling is the thing that I'm most familiar with, and I'm going to use the next couple of slides just to talk about its development and modification since it was first introduced. So the Atom sling is the adjustable trans-obturator male sling. It consists of 6 mesh arms which are drawn around the inferior pubic ramus and attached to the device itself. It has a hydraulic cushion which provides external compression on the bulbospongiosus muscle and the urethra beneath. And it has a silicone-covered scrotal port which allows for post-operative adjustment of the cushion. The first generation device was introduced in 2008. It has a titanium inguinal adjustment port. It requires 2 incisions to insert an inguinal incision and also a perineal incision to position the cushion. The second generation device was introduced in 2013, and in this, the adjustment port was relocated to the scrotum. However, due to concern of a higher than expected explantation rate of 10 to 30%, the third generation device introduced a silicone-covered scrotal port. There's a lack of long-term data in the Atoms device, particularly the third generation model. However, this year we were able to publish a Canadian multi-centered assessment of clinical outcomes from the Atoms device from 9 Canadian centres over a 4-year period. Our primary outcomes were continence, which we defined as less than or equal to 1 pad per day if using more than 2 pads per day pre-op, or 0 pads per day if using 1 pad per day pre-op. Secondary outcomes included improvement, which was defined as a greater than 50% reduction in pad use per day, patient satisfaction, explantation, and 90-day complications. We looked at 289 patients over a 20-month period. It's worth noting that 90% of patients had post-prostatectomy incontinence. 1/5 of patients had previous incontinence surgery, and 1/3 of patients had adjuvant radiotherapy. And the mean preoperative pad use was 4.2 pads per day, and the mean post-operative pad use was 1.4 pads per day prior to adjustment and 0.9 pads per day after adjustment, with 70% of patients requiring at least one adjustment post-operatively. There was a mean change in pad usage of 3.3 pads per day. 73% of patients achieved continence, 89% of patients improved, and 84% of patients were satisfied with the outcomes from surgery. Looking at risk factors for failure on multivariate cost regression analysis, patients who had previous radiotherapy or had a history of diabetes were twice as likely to fail to achieve continence, and increasing pad usage was also associated with a failure to achieve continence. A quarter of patients had some kind of complication post-operatively. However, the majority of these were clavien window 1 and 2 complications. Our explantation rate was 7.9%, and these included 18 patients who had infection or port erosion requiring explantation, 2 patients who had urethral erosion, and 3 patients who failed to achieve continence and had an AUS inserted. In terms of factors associated with explantation, patients who had previous radiotherapy were 2.7 times more likely to require explantation. However, the explantation rate in this group was still only 14%, so we feel that the Athens device is still suitable for use in patients with a history of radiotherapy, provided that they have been adequately counselled regarding the explantation rate. Just as a final word on adjustable slings and the Athens device in particular, it's associated with high rates of continence improvement and patient satisfaction. Prior radiotherapy and diabetes, in addition to increased preoperative pad usage, are associated with failure to achieve continence, and prior radiotherapy was associated with a higher risk of explantation, but as I've explained, this shouldn't be a contraindication to using the device in these patients. In terms of the sling space, there doesn't appear to be any new products in development on the horizon, and I think that the future holds just modifications of the currently existing devices. However, if we look at where we're going in terms of artificial urinary sphincters, there's really been an explosion in terms of the publication rate in this space. And this has also led to new innovative ideas and modifications for the artificial sphincter. The new developments can be grouped broadly into 3 areas. Firstly, in terms of cuff activation methods, we're moving away from mechanically operated pumps towards magnetic and even wireless or Bluetooth activated devices. In terms of complexity, there's a move towards more 2-piece devices where the pressure regulation is incorporated into the pump, and also move towards pre-assembled designs which are easier to insert and also reduce the risk of iatrogenic mechanical failure. In terms of the cuff design, there are a number of devices with adjustable cuffs, and there's also a number of devices which try to employ intermittent synchronized compression of the urethra, which should hopefully reduce the risk of urethral atrophy in the long term. The Zephyr is probably the closest comparator to the AMS 800. It had its first in man in 2019. In spite of this, there's limited outcome data available for the Zephyr. It's composed of a 2-part pre-connected unit consisting of a cuff and a pump. The pressure regulating system is integrated into the cuff, and there's a single cuff size that can be adjusted post-operatively. Lawrence and colleagues reported on 106 patients with 24 months of follow-up, and they reported an 83% cure rate and a 91% improvement rate with a 23% explantation rate. Ostrowski and colleagues had similar results in reporting on 50 patients with 21 months follow-up, and they reported a 58% cure with an 88% improvement, and again a 24% explantation rate. The Victo and Victo Plus consist of a 3 or 4 part pre-connected unit consisting of a cuff, a pump, and 1 or 2 pressure regulating balloons. The Victo has a single balloon, and then the Victo Plus has an additional stress balloon, which it can be activated during conditions of increased intra-abdominal pressure. This device also has an injection port for percutaneous adjustment. The only attempted outcome data published was by Riedel in a correspondence letter reporting on 25 patients with one year follow-up. He reported no explantations of the device, and all patients were reported to be dry or improved post-operatively, although there were no concrete figures given or the assessment tools used regarding this. So I think we're probably waiting on more outcome data to become available before this device becomes incorporated into widestream use. The ARTIST is a quite exciting piece of technology. It had its first in-man trial in 2018 and we're still awaiting outcome data on the device. There was reports of the European launch in 2021, although I'm not sure if this is likely given the current pandemic at least. It's a remote control operated electromechanical device. It has an adjustable urethral cuff that can be adjusted by the remote. It has what's described as a piano cuff where there's synchronized sequential compression of the urethral segments, and as I explained, this is a modification employed with the aim of reducing the risk of cuff atrophy that might occur with long-term compression of the urethra, and then voiding is achieved by pressing the main button. And then the final device I'm going to discuss is the magnetically controlled endourethral AUS, and this was reported in an ex vivo publication in 2017. It has a unidirectional valve that's opened by an externally placed magnet. It can be inserted and removed by a catheter, and distal migration is prevented by the cyclically placed nitinol stent. I would have concerns, as with any endourethral stents, regarding the corrosive complications or encrustations that might occur with long-term exposure to urine, in addition to the migration that we see with endourethral stents. But we'll await further outcome data from this device. And then finally, I'm going to finish by discussing the light in the distance, which I think is stem cell therapy. Most of the studies surrounding stem cell therapy are in relation to female stress incontinence. However, there are a number of studies looking at stem cell therapy in male stress incontinence also. The main cell lines used are adipose-derived cells, myocytes, and fibroblasts. These are harvested from the abdominal wall or deltoid, cultured and injected into the perisphincteric tissue of the bladder neck and proximal urethra. They have advantages over the AUS and sling in that it's obviously autologous tissue, and therefore the likelihood of immune rejection is low. It removes the risk of erosion associated with prosthesis, and they're likely to have a lower risk of pain and infection. However, the safety of stem cell therapy was drawn into question when a woman who had an autologous adipose-derived cell stem cell therapy for female stress incontinence developed a fat embolism and died. In addition, there is another large-scale randomized control trial looking at stem cell therapy in female stress incontinence, which showed no difference to placebo. The challenges with therapy at the moment are the low rate of stem cell survival and the uncontrolled differentiation. A number of research units are looking at the use of hydrogel scaffolding and also to regulate stem cell fate. This was a publication by Wan in the Journal of Investigative Surgery last year. It's a meta-analysis. He identified 6 studies using adipose-derived stem cells, myoblasts, fibroblasts, and the follow-up time was reasonable, but with the exception of the last 2 studies, the number of patients enrolled in the trial were relatively small. And these were all prospective or single-arm clinical studies. In terms of outcomes, the continence rate was only 11% and the improvement rate was 64%. So I think we have a way to go yet before these treatments are really viable competition for the AUS and the SLIM. So in conclusion, over the past 3 decades, I think we've made significant improvements in terms of our surgical technique and post-operative survivorship care in an effort to reduce the rate of post-prostatectomy incontinence. Currently, we have a number of treatment options available for post-prostatectomy incontinence, and improvements are constantly being made to improve the durability and usability of the devices currently available. And then in the future, new technologies to regenerate the native sphincter are being explored, but I think it's some time yet before we'll see them in mainstream use. I'll now take any questions.